Good afternoon, everybody. And at the outset, I'd like to thank Ajanta Pharma and very specially Dr. Rajul Parikh for having me here this afternoon. It is indeed a pleasure for me to be with you here this afternoon. And thank you, Ajanta Pharma, for the overwhelming hospitality, which I shall remember for a long time to come. Thank you very much. With that, I take you through the newer innovations in medical management. I have no financial interest in any of the products. So, why new innovations? Neural damage is irreversible, so we need neuroprotective agents. Patients with comorbidities hardly have much of glaucoma medications which we can prescribe. There's a need for preservative free drugs for those who can't tolerate the preservatives, and drugs with newer delivery systems to improve compliance. So, just a word about aqueous humor dynamics. We all know that trabecular outflow is about 70 to 80%, and uveoscleral outflow is about 20 to 30%. How do the drugs act in glaucoma? Their only single goal in today's medications is to reduce intraocular pressure by either reducing the production or by increasing the outflow. So the outflow drops, as you see out there. The newer ones are nitric oxide donating molecules and rheokinase inhibitors, and the aqueous suppressants are the same as we use since last 2 decades. So rheokinase inhibitors increase aqueous outflow and decrease outflow resistance by increasing the stability of ability of the Schlepp's canal of the endothelial cells to form pores. So we have ripasudil and netasudil. Ripasudil hydrochloride in zero point 0.4 reduces IOP about 2.5 millimeters at trough and 3.7 millimeters at peak. The most common side effects include conjunctival hyperemia, blepharitis, and allergic conjunctivitis. Netasudil, on the other hand, also acts with a norepinephrine transporter inhibitor, which decreases IOP by decreasing the outflow resistance, and in addition to netasudil caused by reduction in aqueous humor production in animal studies. So if you have a look at this, today we use the netasudil and the ripasudil, and the studies that were conducted, Rocket 1 and 2 studies, in which netasudil was compared with timolol and found to be equal to timolol, and the Mercury 1 and 2 studies, in which netasudil and latanoprost were compared. So this is a new molecule, latanoprost brunoid. So it actually is 0.024%, is a unique nitric oxide donating prostaglandin F2 alpha. And this is how it works. You have the flow chart in front of you. So in the eye, nitric oxide synthesizes are present in the Schlepp's canal, trabecular meshwork, and ciliary body. So nitric oxide causes vasodilatation and smooth muscle cell relaxation. It decreases cell contractility and volume and thereby increases the trabecular outflow. That's how it works. And this is a head on study which was done between Visulta and Xalatin, and it was found to be more potent in IOP lowering than Xalatin did. So LBN is currently dosed at once daily at night. And these were the landmark studies done by Wenreb et al. Voyager study, in which they definitely said it works well on primary open angle glaucoma and ocular hypertension. And then we have the Constellation study. And finally, we have the Apollo and Luna studies, in which it said that it was, one of them said it was better than timolol, the other said it was non inferior to timolol. So that's how it opens up the spaces that you see out there. The most frequently reported side effects of this drug are the same as the prostaglandin analogs, like you have a gradual cosmetic changes like iris pigmentation and eyelash growth, conjunctival hyperemia, and the rare complications like worse iris gets worse, or in macular edema or posterior lens capsule, it can cause uveitis. So selective prostaglandin EP2 receptor antagonists. So in this you have the brand name Omlontin, but we don't have it here as of now. So I'll move on to the sustained release drug delivery systems, in which we have Durista, that is the bimatoprost sustained release. And this implant is administered into the anterior chamber using a 28 gauge single pre-filled applicator. The drug delivery system is made of biodegradable polymers, and there are no adverse effects related to eyelash growth, etc. But the main concern was the drop in endothelial cell count, and that's the reason there was the phase 3 trial actually was stopped. So intracameral implants, now we have the iDose TR, and which is from Glucose. It's still not in our country. And then we have the contact lenses, which are actually uh, eluted with the drug. So none of these are there in our country. So I'll just mention them, not to give time to them. So sustained release applications of bimatoprost ocular rings are also there, which are yet to come, and they reduce the diameters are between 24 to 29 millimeters and continuously elute bimatoprost over a period of 6 months. It needs to be replaced after 6 months, and the drug elution decreases with time, ranging from 35 milligrams per day on the day of insertion to as low as 6 milligrams per day at 6 months. So, IOP control is over 6 months. So, the main adverse effects are mucinous discharge that and the phase 3 trials are awaited and is not yet FDA approved. And then there are also travoprost intercanalicular inserts, which are there, but not in our country yet. Neuroprotection is a term which we've been talking about for a very long time in glaucoma, but till date, we still don't have something which is neuroprotective and evidence proved. Cannabinoids are not legalized in our country, and there's still work going on genes and stem cell therapies. So, in the pipeline, we have a lot of products like travoprost loaded microparticles embedded with biodegradable, programmable hydrogen matrix that encapsulates drug to provide sustained localized delivery. We have the Meti Therapeutics, which is coming out with the latanoprost eluting punctal plug. We have the sustained release prostaglandin and prostaglandin timolol combinations, which are on the pipeline. Then we have small interfering RNA, blocks the B2 adrenergic receptors. These are all on the pipeline. Then the Spyglass Pharma is coming out with something as well, where the intraocular lens that you implant in cataract surgery would actually release the drug over time. Then you have Polyactiva is developing latanoprost FASR ocular implant. You have the Envisia Therapeutics, which is developing travoprost sustained release, and Glucose is coming out with the next generation of iDose very soon. So the drug delivery now and on the horizon is biodegradable intracameral implants. Then you have non-biodegradable intracameral implants, and finally the external biodegradable intracameral implants. So the AO25 glaucoma medical management innovation takeaways were sustained release therapy will play a central role in long-term IOP control. Better visualization creates safer, more effective surgery, particularly in angle-based procedures. Lens selection for glaucoma adjacent conditions must be individualized and not generalized. So, from medication independent pressure control to enhanced surgical precision and tailored IOL planning, AO 2025 signaled a maturing field moving towards durability, predictability, and personalization. So, just as the aurora borealis, which you've been seeing for the last 7 minutes on the screen, illuminates the night sky, these innovations illuminate a new era in glaucoma management, offering fresh hope for preserving vision and improving the patient's quality of life. Thank you very much for your attention.